Okay, this lecture is for Thursday, and there were some technical problems with the recording, and so I'm re-recording this lecture. As we were getting started, I was making a few changes to your handout. Please note that today I'll be finishing up the lymphatic system, and honestly won't be talking about two sections in your notes. And I would like you to review on your own the 20.8 and the 20.9 modules. And then also at the very, very end, there's a couple of conditions where the immune system goes awry, and that's 20.21. Those sections you'll do on your own. Please go ahead, though, and delete sections 10 and 11 from your note pack. I will not be covering those specific cellular responses as part of the immune system. Last time we talked about the different structures and the overall story of the lymphatic system, and I would be pleased to entertain any questions about that. If there's anything about the lymphatic vessels, the lymph nodes, or just the overall arrangement of the immune system, or I should say the lymphatic system, please let me know. We'll be picking up a little further down into the presentation, so I'm going to skip ahead through the slides that we talked about last time. And recall, we discussed the overall purpose of the lymphatic system. We looked at the location of all the lymphatic organs and the MALT type tissues. Talked about the lymphatic vessels and the fact that your interstitial fluid, which is really the same as plasma, those names, plasma, interstitial fluid, and lymph, really all refer us to where that fluid is. It's plasma when it's contained within blood vessels, it's interstitial fluid when it's freely between the cells, and it's lymph when it is incorporated into the lymphatic vessels. We mentioned how the lymphatic capillaries are discontinuous. They have overlapping endothelial cells, and there are veins which help keep the lymph flowing, since these vessels are under very, very little pressure. There are four, there's areas of the body where there's a concentration of lymph nodes. Those are in the cervical region, the axillary region, and the inguinal region. And then there was also an interesting asymmetric collection of all that lymphatic fluid. So the thoracic duct is draining both legs and the left side of the head, neck, and arm, and the right lymphatic duct is receiving all of the fluid from the right arm, the right side of the head, and the right chest. And then both of those ducts are draining into the respective subclavian veins. When too much fluid accumulates in the tissues, and there's a couple different reasons why that happens, that is lymphedema. And we looked at some pictures last time of elephantiasis, and there can be other reasons like surgical or any kind of trauma that can block those lymphatic vessels, and that can then result in an accumulation of that lymphatic fluid. I introduced you the different types of lymphocytes: T cells, B cells, and NK cells. We discussed where they are originating. And it seems to me that that's about as far as we got. We talked about the location of the lymph nodes and the location of the tonsils. I will not ask you to know the histology of any of these tissues. So if there's any issues with histology, do not be concerned about my asking about them. I do want you to know, though, which of the lymphatic structures are encapsulated and which ones are not, and I'll be discussing that as we go through. So we have the tonsils, three pairs of tonsils: the pharyngeal tonsils found in the nasopharynx, the palatine tonsils found on either side of the uvula, and then the lingual tonsils, which are deep to the base of the tongue. And that brings us up to lymph nodes. Now, lymph nodes are have a connective tissue capsule around them. They sort of look like small kidney beans, and they can be very small, up to even 1 inch in diameter. The largest lymph nodes are located in the neck, the groin, and the axilla region, the same places where you have the greatest collection of lymph nodes. And what these lymph nodes are doing is they are filtering that lymphatic fluid as it's returning back into the general circulation. And about 99% of all the pathogens will be removed as they move through this lymphatic system. And then keep in mind this is constantly circulating so that if it doesn't get it the first time, it'll get it the second time as these pathogens go around, toxins or other foreign entities. Lymph nodes are interesting. Lymph is going to flow into a lymph node through the afferent lymphatics. Remember, the term lymphatic simply is a general name for any of the vessels, and it's going to come in to the node on the opposite side of the hilum. The hilum is the indented place where other structures go into and out of this rather solid lymph node. And then it's going to go into a subcapsular space just underneath the capsule. And here there will be some dendritic cells. Dendritic cells, think here macrophages. So there are going to be large cells that can phagocytose some of these foreign bodies. Then from the subcapsular space, the lymph will flow into the outer cortex. And it's here that there are a lot of B cells. Recall that B cells are your antibody-producing cells. From that outer area, they're going to go to the deeper cortex, and here there are T cells. So as you see, the lymph carrying potential toxins, virus, bacteria, whatever has gotten into that lymphatic fluid is going to go by phagocytic cells, it's going to go by antibody-producing cells, and go by various T cells. And this will allow basically the entire, much of the cellular immunity to be able to interact with or destroy these foreign antigens. Once it has gone through these spaces, it will go into a medullary sinus at the very core, and then out an efferent lymphatic, traveling out of the hilum and back into the venous circulation. So you can see here the flow. Again, afferent, passing by where there are some dendritic cells, the outer cortex with B cells, the deep cortex with T cells, out the medullary sinus, and out the efferent arteriole. And lymph would then potentially go to another lymph node, where again there would be another opportunity for filtration and for the monitoring of these foreign bodies. Now, what can go wrong? MALT, recall mucosa-associated lymphatic tissue, is tissue found along epithelial areas, for example, in the throat, along the gut, and along the bronchioles that we'll see again when we get to the respiratory system. And if the MALT is overly active, it will become inflamed. And an example of this would be tonsillitis. So inflammation of the tonsils from repeated activation of the immune system. Appendicitis, similarly, these can be very painful and even dangerous situations, leading to the removal of those tissues. So I want to discuss the thymus and the spleen, and then that will pretty much finish up this chapter on the lymphatic system. So the thymus is important in that it produces a number of hormones. These are collectively called the thymosins. The thymus is very important in the functional development of T cells. Recall that all of the immune cells are produced initially in the bone marrow. And that is true of the T cells as well. But before they even finish their early development, they're going to be transferred to the thymus, hence their name T cells for thymus. Now the size of the thymus is going to decline with age. It's going to be largest before puberty. It's going to get smaller and smaller. That is, it involutes or it undergoes involution throughout your life. By age 50, it is about 1/4 the size that it was. And that means that elderly people are more susceptible to disease because they don't have the T cell production going on as robustly as they did before. So not only are they more susceptible to infection, viruses, and colds, but also the ability of the immune system to catch, if you will, tumor cells and cancer cells starts to decrease, so the incidence of cancer is on the rise in the elderly. This is actually a very, very large thymus, so I'm not a fan of this picture. It does show, though, that the thymus is located on the superior base of the heart. It is in the mediastinum, found pretty centrally between the lungs. It would not be, however, this large in an adult. So imagine it's about this size proportionally to the heart in a young person, but by adulthood, this would have involuted to a much smaller size. In many drawings, if the artist is referring to the lymphatic system, it will almost look like there's a smaller or a very large thyroid gland. Here's a thyroid gland up here. Clearly, it's up in the larynx area, and so some people will mistaken the thymus as a thyroid in a very strange place when labeling some diagrams. The thymus is going to be a very grainy, pink, epithelial-like organ, again located in the mediastinum posterior to the sternum, and it is covered in a capsule that will divide it into right and left lobes. There will be fibrous tissue partitioning the lobes into smaller lobules, with each lobule being about 2 millimeters in diameter. So here you can see that the overall thymus, left and right lobules, and each little section separated by the septa, creating a lobule. If we then take a look at each lobule, you'll see that there's an outer dark cortex. This is where the cells, where the lymphocytes, the T cells, are arranged in clusters surrounded by thymic epithelial cells. These TECs are very, very important in the T cell development, and they are actually some of those thymic education cells. Here, the cells would be destroyed. I mentioned last time that about 98% of T cells are destroyed during their development because the immune system, while it's creating those T cells, goes through a selection process. And if those T cells have any identity toward self, then they will be destroyed. So you have a darker stained cortex and a lighter stained medulla. That's the same arrangement of dark and light that you have, for example, in the brain. So I always think of these little lobules being in the same light and dark arrangement as the brain. And also, these epithelial cells are maintaining what's called the blood-thymus barrier. And we've seen the blood-brain barrier. We'll see the blood-testis barrier when we get to the male reproductive system. These are important places in the body where the immune system would potentially cause harm, or during the development harm would come. So we want to make sure the blood, the general antigens floating in the blood, are not influencing the thymic education. After about 3 weeks, in the cortex, the cells will move toward the medulla, and there's no blood-thymus barrier there. And eventually, those developing T cells that have passed their education, passed their screening, will move into the blood vessels and now will be traveling throughout. And they'll go to some other organ. So in this micrograph, you can see, again, if we slice through a portion of the thymus, you can see a different lobule here, and you can see that there's a center area that is lighter stained, the medulla, the medullary area. The outer area, you can see the darker cortex. So the lymph nodes, as you know, were the screening organs for lymph traveling through lymphatic vessels. The spleen basically does the same job for the bloodstream. So not only do you have the lymphatic system screening fluid through lymph nodes, but the spleen is also constantly screening the blood as it passes to the spleen. It's going to, in addition to containing a large mass of lymphatic tissue and cells, it's also going to remove abnormal red blood cells. You know that red blood cells only circulate for about 120 days, and just like the money in our society, the treasury is getting rid of old, worn-out $1 bills, same idea. As the cells start getting worn out, they're removed from circulation by phagocytosis. As those red blood cells are destroyed, there's also a recycling of the iron, and if an antigen is found in the circulating blood, then that can activate these T cells and B cells in response to those antigens. So in an infection that reaches the blood, the spleen can become enlarged. If you have an infection and your lymph nodes are swelling up, then you know that your immune system is actively fighting off some infection that was discovered, if you will, or activated the T and B cells within the lymph nodes. Likewise, if there's a blood-borne infection, the spleen can become very enlarged in response to the immune system ramping up its response against that foreign antigen. The spleen, at gross anatomy, lies along the lateral border of the stomach. It's on the left side. If you recall the fetal pigs, it was the same arrangement. The spleen in the fetal pigs was that little long, thin, tongue-like structure on the left border of the stomach. In the human, it's also on the left side. There is a gastrosplenic ligament that is going to hold it in place, if you will. There's also a diaphragmatic surface that is very smooth, that is up against the diaphragm. Looking at this slice through the thoracic region, the abdominal pelvic region, you can see that the liver, the largest abdominal organ, is over here on the right side. The stomach is pushed over to the left, and the spleen is associated with it through that gastrosplenic ligament. You can also see on here 2 kidneys. It gives you an idea of where we are. There's still some ribs here. These are the floating ribs, so we're down around T10, T11, T12. And you can also appreciate that if the spleen were to become enlarged, that those floating ribs could damage the spleen. The spleen is so filled with blood, such a vascular organ, that damage to the spleen during an infection is a very serious consequence and a very large hemorrhage. You'll also see that in this diagram, the more yellowish pancreas located anterior to the kidneys. So as I mentioned, there's a lot of blood going to the spleen, and because of that, when you're dissecting it, it'd be very deep red. It's very soft, and another word for that is very friable. It's really not the most intact type of structure, so it can be easily broken or broken down. Again, on the visceral surface, there's 2 indentations on the spleen. There's a gastric area, and there is a renal area. And the hilum, as I mentioned before, is the area into which most of the lymphatics, arteries, and veins are traveling. So the hilum of the spleen shown here. The fact that the spleen is able to rupture easily and is very, very fragile and therefore not easy to repair, the word for that is that the spleen is very friable. The spleen is very friable, very fragile, difficult to repair, and if it gets damaged, may require a splenectomy, which is important. Life can go on without the spleen, but certainly the immune system is damaged or not able to be as robust if the spleen is removed. If you look internally into the spleen, you'll see the outer capsule of collagen and elastic fibers, but inside trabeculae. Now, trabeculae is a word that you'll see in a number of places. One place that comes to mind for me is thinking about bone. And in the outer layer of bone, we had cortical bone, or the compact bone, and then internally there was the medullary bone, or the spongy bone, which was always described as having trabecular spaces. So this is a very spongy-like structure radiating out from the hilum, and this gives lots of space for blood vessels to come in and for blood to be filtered as it passes through layers or areas of these immune cells. In the very center is red pulp and white pulp. The red pulp are areas of large macrophage concentrations, and this is also because of the color where a lot of red blood cells are found. The white pulp is more of the lymphoid nodules, almost like, imagine, little sections of lymph nodes filled with lymphocytes. Again, the whole purpose of the spleen is to remove microorganisms and damaged cells from the bloodstream. Under the microscope, what you would notice is that there's the capsule, the outer layer of the spleen, and then this trabeculi, this kind of loosely arranged area with concentrated areas of red pulp and white pulp, areas where there's more lymphatic structures. So again, the blood's going to come in. It's going to go through the branches. The trabecular arteries are branches of the splenic artery. So the splenic artery is bringing blood in. Then the trabecular arteries, that's going to bring you into the white pulp area. It's going to go into then the red pulp areas where there are a bunch of macrophages, flow through the sinusoids where there are spaces where the blood is being filtered, and then collect back out through trabecular veins out at the hilum and back into circulation. The next two sections, 20.8 and 20.9, I'd like you to read over on your own. You can cross off 20.10, 20.11, and I don't believe you even have anything from 20.12 in your notepad. So cross those sections out. It's very basic ideas about how your body basically is able to fight off infection. And then at the end of these two short sections on the physical barriers that contribute to the lymphatic system, I then want you to go over to the last section, 20.21, and now look at some of the, you're skipping over this, not responsible for 2010 or 11. Don't go into the complement system. You'll get those things in microbiology. And then jump over to 20.21, and here I mention a couple of different autoimmune diseases where the body begins to make autoimmune antibodies and misbehave in other ways. Diseases like rheumatoid arthritis and inflammation or associated with type 1 diabetes are all autoimmune, multiple sclerosis. Graft rejection, when a tissue is no longer accepted. Oftentimes we think about the blood cell connection, but it's a lot more than that. And then even allergies being really an excessive or misdirected immune response. So take a look at those last few slides, and that finishes up the section on the lymphatic system. Well, now that we've finished the lymphatic system, that'll be the first system of the next exam. The next system we'll start discussing is the respiratory system. I've left the first 6 modules in your PowerPoint so that you could review these structures. The first 6 modules are, however, a review of Biology 105, Anatomy, and Histology. So do review through that. Let me just go to a couple of main ideas, and that is that the respiratory system can be broken up in a couple of different ways. Recall that there is an anatomical division between the conducting and the respiratory. This is a physiological division. This is between the conducting portion and the respiratory portion. So the conducting portion is pretty much the straw that brings the air down into the respiratory system or the respiratory portion. The respiratory portion is just the last little bit of microscopic structures that includes the smallest bronchioles referred to as respiratory bronchioles and the alveolar air sacs. That's where the gas exchange actually happens. Everything before that, proximal to the respiratory portion, is simply an area where gas is going in and out, but there's no gas exchange occurring. You can also divide up the respiratory system into the anatomical divisions, very simply upper and lower, and the dividing line here is the larynx. The larynx is the first part of the lower, LL. So the larynx goes with the lower respiratory system. So you could simply draw a line right about through the larynx, and everything above it is upper and everything below it is lower. Pretty simple. Remember that the epithelia of the respiratory system, you have pseudostratified columnar. That pseudostratified columnar is going to be found in the nasal passages. It's also going to be found in the sinuses themselves. Of course, once you go through the oropharynx, in the laryngopharynx, there you have stratified squamous, similar to the esophagus and the oral cavity. And then returning back to the trachea, you're back to the same respiratory mucous membrane with the pseudostratified columnar with cilia and goblet cells. As you move down into the bronchial areas, now you lose the mucus and you have more of a cuboidal epithelium, and finally at the alveoli you have the simple squamous epithelium. So definitely be familiar with and be thinking about the functionality of that histology. Review please the sinuses, the three different parts of the pharynx, the structures of the respiratory system. You should know these structures very nicely as you have labeled all those previously. Remember, the epiglottis is what will swing down to cover the opening, which is the glottis, the entryway into the larynx. Recall that the big pieces of cartilage that I want you to know are the thyroid cartilage and the cricoid cartilage, and that is all we'll concern ourselves with this semester as well. Recall that in the larynx there's also the vestibular ligaments, and vestibular ligament is simply the meaning opening into the vestibule, and then the vocal ligaments below that. Remember, you may have called those the false and true vocal cords in the past. The trachea is characterized by C-shaped, large C-shaped pieces of cartilage, and the trachealis muscle is at the posterior portion of the trachea with the esophagus directly behind. Where the trachea splits into the right and left primary bronchus is the carina, C-A-R-I-N-A. And recall that the primary bronchus, the right primary bronchus was more vertical, larger, because there's more. The right lung has 3 lobes. The left lung only has 2 lobes, therefore only 2 secondary bronchi. The bronchioles no longer, as we move down the bronchioles, there's less and less cartilage, and they are kept open simply by smooth muscle. It is in these bronchioles where they can close down during an allergic response or during asthma, blocking off the air supply. So definitely review the flow of air through the respiratory system. Review the overall anatomy of the lung. And I want to pick up as we go down into the alveoli. Each lung has about 150 million of these little alveolar sacs, and if you were to spread all of the alveoli out, it would have the surface area of a double tennis court. Recall that the blood flow down to the alveoli is part of the pulmonary circuit, so the pulmonary veins are red and the pulmonary arteries are blue. I'll pick up here and move through the rest of the content more slowly. So there are 3 types of cells down in the alveoli. The most numerous, what you probably think of first, are the type 1 pneumocytes or nematocytes. And these cells are the simple squamous cells across which gases diffuse. The second type of cell, type 2 cells, are the ones that specifically produce surfactant. Surfactant is a detergent-like molecule that prevents the collapse of the alveoli by reducing the surface tension. Without this surfactant, the little alveoli would collapse down because they're so small. Preemies are born without sufficient surfactant, which gives them respiratory distress because their lungs are not yet developed, and the little alveoli tend to collapse down. Finally, there are some roaming macrophages. These are called the dust cells, and just imagine if you're breathing in, if small particles like, quote, dust could get down all the way into your alveoli, these dust cells, these alveolar macrophages, would phagocytose those things that could potentially clog up the alveolus. So just to get imagine this cartoon representation of the little alveolar sacs, the vast majority of the cells are the type 1 cells, simple squamous epithelium, remember tightly packed cells, very, very thin layers. You also see there's a great number of capillaries in this drawing. So I'll just show you the capillaries in red. All those are capillaries where gas exchange is occurring. And then you'll also see some type 2 cells. They're shown here as yellow, and those are a distinct cell type that makes the surfactant. Finally, there would be some wandering alveolar macrophages. Again, these are also called the dust cells. Now, it's very important that the simple squamous cells, the type 1 cells, are very thin. They can be as thin as 0.1 micrometers. The average thinness is half a micrometer, and that is referring to the entire respiratory membrane. The respiratory membrane is specifically referring to a 3-layer membrane. It's really a double epithelial layer. If you think about being an oxygen molecule and you've just been brought into the lungs and down into the alveoli, that oxygen has to cross the alveolar epithelium, simple squamous, type 1 cells. There would be a very thin basement membrane, on the other side of which there would then be the epithelium of the capillary, and that's called the endothelium. So remember, the endothelium is just a special name for the simple squamous cells that line the inside of a capillary, actually inside of any of your vessels. So to see the cartoon representation of this respiratory membrane, it is a fusion of 3 layers: the alveolar epithelium, a very thin basement membrane gluing it all together, and the capillary endothelium. And it's across this space that oxygen must come in and that CO2 must be removed from the capillaries of the alveoli. So really what we're going to be dealing with now is the respiratory physiology. You know the anatomy of the respiratory system. Respiration is really 2 processes. External respiration, that is bringing in gases from the external environment, is the bringing in of gases through pulmonary ventilation or through breathing. This is going to be bringing air in and out and getting air down into the alveoli, so that that oxygen can then be taken up into our cells. Now, when cells take up that oxygen from the blood, they are going to make, through the process of cellular respiration, here they're going to be making CO2. So when a respiratory therapist or physician refers to respiration, they're usually referring to ventilation, air in and out of the lungs, and availability of oxygen into the body. When a biologist, a more of a pure biologist, refers to respiration, they may be instead referring to cellular respiration. The idea that every cell in your body must take in oxygen, must take in energy, and from that, through the process of glycolysis and the electron transport chain, is going to make CO2 as a waste product. So look at the context of the reading and the writing and the conversation to understand, is this person referring to respiration in a more bodily system, or are they referring to respiration at more the cellular level? When we think about respiration, though, moving on, I won't be dealing too much with the cellular respiration. Just know that oxygen into a cell, waste product CO2 is released. What we're dealing with now, and what we're really going to be focusing on, is at the respiratory membrane. And what is the exchange of oxygen and gases from the alveoli into the capillaries and vice versa. Clearly, the whole purpose of bringing air into the body is so that the cells can do cellular respiration. So let's put these 2 processes together. So external respiration, bringing air into the body, that's going to bring air all the way down into the lungs. And there, through the process of diffusion, oxygen will transport into the tissues. Once the oxygen is in the tissues and in each cell, that's where internal respiration occurs. That internal respiration of each of your cells is now producing CO2. That gas will diffuse out of the cells into the capillaries, be transported back to the lungs, and then sent out through external respiration into the environment. Now, if there isn't enough external respiration, then we can use these two words to describe that. Hypoxia would be low tissue oxygen levels, and also going along with that, if a person has hypoxia, you may also hear it referred to as hypoxemia, and you know that emia is referring to an abnormal condition of the blood. So hypoxia would lead to hypoxemia, that is low levels of oxygen in the blood. If you don't have enough oxygen in the blood, then the cells are not able to do their metabolic processes. So now we see again the connection between external and internal respiration. Anoxia would be a complete lack of oxygen, and we know that the heart and the brain are not at all able to go without oxygen. So a situation of anoxia can very quickly lead to damage, permanent damage, to both the heart and or the brain. So we need to figure out a little bit about gases as oxygen comes into the lungs. Recall somewhere along a physical science or a physics or chemistry class, you know that gases bounce around within the container in which they're held, and they bounce around independently. And these little air molecules are bouncing off each other, and as they bounce off the side of the container or the lungs, they're creating pressure on that structure, on that container. And there was a scientist of old called Boyle, and he described what is now called Boyle's law. And Boyle's law basically says that pressure is inversely related to volume. So, for example, if I have a container and the little black dots represent various gas molecules, and those gas molecules will be zinging off and bouncing off the sides of the container and other molecules. Those molecules bouncing off the container will create a certain amount of pressure, and the volume here is the same. So we have a fixed volume and a fixed pressure. But if I begin to push in on the size of this container, therefore the volume is going down, the pressure inside would increase. So we see that they're inversely related. Inversely, if I were to enlarge the area, that would increase the volume. There'd be fewer molecules pushing on the side of the container, and so the pressure would go down. So with increased volume, pressure goes down, and vice versa. This is Boyle's law. So this brings us to understanding what happens as the thoracic cavity expands. As the diaphragm at rest is a dome, and your lungs superior to that dome, and during inspiration the diaphragm flattens out. The ribs go out a bit, and even the upper ribs can elevate. The sternum and the breast, the ribs can also move more anteriorly. What's happening is that as these muscles are moving, there's going to be an increase in the volume of the thoracic cavity. With that increase in volume, the pressure is going to go down. So as long as we remember Boyle's law in this inverse relationship, what I'm about to describe will make very good sense. So again, as you inhale, there is a change in the thoracic cavity as is described here. Now, if you're sitting at rest and for just a moment you are not breathing, as I stop saying something and I stop breathing, At that moment, there's no air movement in or out of my lungs. That means that there's no change in pressure. The pressure inside the lungs, that is the intrapulmonary pressure, and outside, the atmospheric pressure, are the same. So if the intrapulmonary pressure and the atmospheric pressure are the same, there would be no movement of air in or out. As I expand my thoracic cavity, as I use the diaphragm as kind of flatten, and as doing so, remember the parietal pleura attached to the thoracic wall and the visceral pleura attached to the lungs create basically a vacuum seal. And as the thoracic wall expands, the lungs will be drawn with it. That increase in volume will again decrease the pressure. Now, if for some reason that pleural cavity, the bond is broken, the serous membrane is damaged, then the lung can collapse. And that's sometimes also referred to as a pneumothorax. So any sort of damage to the pleura, such that that vacuum seal is broken, can lead to a collapsed lung. So a reminder about that serous membrane, a double layer around the lungs. And here you can see the doming of the diaphragm. And at rest, when no air is moving in or out, the pressure outside would be equal to the pressure on the inside. During inhalation, again, increasing of the volume of the thoracic cavity. At that point, so if I increase the volume, the pressure goes down. So now the pressure on the outside is greater than the pressure on the inside. And as a result, air will move into the lungs. We have around us a consistent atmospheric pressure. I'll introduce the number in a moment, but there's always pressure moving air and moving the atmosphere toward or into a place of less resistance. So as you inhale, there's 760 at sea level, 760 millimeters of mercury of pressure that is surrounding us and pushing that air into the lungs. Now I want you to look at that number. We're also using millimeters of mercury for blood pressure. And when you take one's blood pressure, you're going to increase the pressure of the cuff to around 180, maybe 200 millimeters of mercury. And we can all appreciate how much pressure that is on the arm. What we're not aware of, because we've been surrounded by this atmospheric pressure all of our life as we develop and as our muscles develop, is that we have an even greater amount of pressure pushing on our body all the time, 760 millimeters of mercury, pushing on us that we're really kind of, quote, unaware of because it's just a part of our normal experience. Now, as we exhale then, and the thoracic cavity is decreasing in its volume, that means that the pressure would be going up. So as we exhale, the pressure on the inside is greater than the pressure on the outside, and that's going to force air back out of the lungs. So just to see this in pictures, as long as there is less pressure in the lungs, then air will come in. And as the diaphragm goes back to its domed position and as the intercostals push the lungs in, that's going to push air out when the pressure of the lungs is greater than the atmospheric pressure. So let's think about what happens then at high altitudes. So you go out to Denver, which is a mile-high city, so it's at 5,280 feet above sea level, and there the atmospheric pressure is lower. You'll hear people say, oh, in Denver there's less oxygen. Well, that's not true. In Denver, there's still a 21% or 20.9%, I'll say 21% oxygen content in the atmosphere. So that doesn't change. What changes is the atmospheric pressure. So as one goes up, as high as Denver, there's a rather significant decrease in atmospheric pressure. Well, if there's less pressure, that means that as your lungs expand, there's less pressure pushing air into your lungs. So in effect, your body receives less oxygen, not because there's less oxygen in the air, but but because the pressure is lower and not as much air is brought into your lungs upon inspiration. This is why teams who go, for example, to play the Denver Broncos try to get out there a little bit earlier than usual to let their body adjust. It takes about 5 days for the body to fully adjust to the atmospheric change, and that's also why there's oxygen masks on the sideline, because it is much more difficult to do your normal exercise routine at higher altitudes until your body has had a chance to adjust. If you want an advantage, you could argue that Denver has an advantage when it travels to a sea level team because they're so accustomed to training at high altitudes that their body has a higher hematocrit, higher hemoglobin levels, and therefore has a doping effect, and they would have more respiratory stamina when working out or when playing a game at lower altitudes. So again, there's a pressure differential between the atmospheric pressure and the pressure of the intrapulmonary pressure. And the difference is what is going to move air in and out. So during inhalation, intrapulmonary pressure is less than atmospheric. This is what we call a negative pressure. So air is pulled into the lungs. So I just think this is a negative pressure, so it's pulling air in, versus during exhalation, the intrapulmonary pressure is greater than atmospheric. This is referred to as a positive differential, and air is pushed out. So a positive, think up if you will. So in a positive pressure differential, air will move up and out of the lungs. In a negative pressure differential, air will move down or into the lungs. Now, this is measured in millimeters of mercury, and the number I introduced to you a moment ago was 760 millimeters of mercury. That is what's found at sea level. Now, the difference as you expand your thoracic cavity and the pressure drops in the intrapulmonary space, this is not a huge difference. What I want you to see is that between inhalation and exhalation, where there's no pressure change, where pressure is zero, there's no movement of air in or out. When you inhale, the difference in pressure is less than 2. So there's a relatively small change. So there's a very small negative change, but that change is sufficient for you to breathe in. And then when you exhale, there's not that much of a difference in positive pressure causing you to exhale. Now this graph is showing us that the normal inhalation is about every 4 seconds. So that would suggest that a person is breathing about every 15 times per minute. And we'll use different numbers between 12 and 15 breaths per minute. Now, something else I want to introduce to you that we'll be moving into in a graphical representation in a moment is tidal volume. Tidal volume is the amount of air that the average person breathes in and breathes out at rest, no stress, just sitting there and breathing. And tidal volume, again, all these numbers are normalized off that idealized 25-year-old, 150-pound male. And that number that we'll be discussing is 500 milliliters. So as you inhale and as you exhale, there's a movement of 500 milliliters of water called the tidal volume. Think of how the tide ebbs and flows, not during a storm, but just at normal times, the ebbing and flowing of the tide. That's your tidal volume, moving in and moving out. Now, if there's a storm, we'll talk about how energy can create a greater increase or decrease in your inhalation and exhalation. But tidal volume is what you're doing at rest normally. So 760 millimeters of mercury, that is normal atmospheric pressure at sea level. Now, 760 millimeters of mercury, that's a big mouthful to say. There's another unit of measure called the torr, described after the scientist who named it, so it's normally capitalized. And 1 torr is equal to 1 torr is equal to 1 millimeter of mercury. So you can replace the word millimeter of mercury with torr, and you'll also hear some people describe all of this 760 millimeters of mercury is sometimes equal to 1 atmosphere. Okay, so you've got different units that can be used, and so you've got 760 millimeters of mercury, 760 torr, or 1 atmosphere, all the same. In a hospital setting, when gas pressures and anesthetic are given, they'll talk about centimeters of water, and you'll also hear about PSI. I won't be using those numbers in this class. So what muscles are involved? Your inspiratory muscles. What muscles allow you to inspire? At rest, or what is called quiet breathing, when you're just breathing normally, 75% of that work is being done by your diaphragm. You know where the diaphragm is located. The other muscles are the external intercostals. They're providing for the other 25% of the movement, and those muscles are elevating the ribs. Now, there are other muscles, the accessory inspiratory muscles, that can be activated when you want to breathe in deeper or when you want to breathe in more quickly. So if you want to breathe in faster or you want to breathe more deeply, then you would recruit these other muscles. And this is going to include the sternocleidomastoid. You know the location of the sternocleidomastoid. You know the location of the scalenes, 3 scalenes on each neck. You know the pec minor, and you know the serratus anterior, also in the abdominal pelvic area. Sorry, the thoracic area. So those are shown here. Primary muscle, diaphragm. External intercostals, those are quiet breathing, normal breathing. Those would allow you to do normal tidal volume, 500 mils up and down. And if you were going to be blowing out a birthday cake or exercising and you needed more oxygen more quickly and faster, you would now recruit sternocleidomastoid, scalenes, pectoralis minor, and serratus anterior. And you can see now from the side view how those muscles would lower and raise and create a larger thoracic cavity. Now, during normal expiration, during primary, there are no primary expiratory muscles. Quiet breathing or tidal breathing is a passive process. The relaxation of the diaphragm, the relaxation of the external intercostals, and the elasticity of those muscles allows now for exhalation to be a passive process. There are, however, accessory expiratory muscles. If you are trying to blow more air out than you normally would, let's say you're blowing out a birthday cake, candle, then you want to take in that biggest breath, that's using your inspiratory reserve muscles, and then you want to blow out forcefully and as fully as possible, then you would also recruit these accessory expiratory muscles. This is going to allow, again, the movement of the thoracic cavity to decrease more quickly and allow more airflow to move out quickly. This is going to include muscles like your internal intercostals, transversus thoracis, your external obliques, internal obliques, and the rectus abdominis. So again, normally, expiratory muscles, it's passive, primary. There is no primary muscle. During accessory blowing out, you're going to use the muscles as listed here. From a lateral view, you can also appreciate that all of those muscles are going to be causing the thoracic cavity to decrease its volume, therefore increase its pressure. Now I want to finish up this discussion with the pulmonary volumes in lab, not next week. Next week we have the lab exam followed by the blood lab. But in 10 days or so, you'll be doing the respiratory lab. And the respiratory lab we'll be doing some respirometry. And as that name suggests, we're going to be measuring respiring volumes. And the volumes you'll need to appreciate, and we'll look at these numbers more specifically in lab, and I'll pick up with this conversation in the lecture on Tuesday. But there's the tidal volume. I've already described this to you. This is the air that you're moving in and out of your lungs during each cycle, or this is a cycle, and this is about 500 mils on average for that average person. There's also an inspiratory reserve volume. If you are going to take in a deeper breath than normal, then you are tapping into the IRV, into the inspiratory reserve volume. If you are blowing out that birthday cake candle, and now you're blowing more air out than you normally would in your tidal volume, That amount is your expiratory reserve volume, or your ERV. There's also residual volume, like residue, what's left behind. The residual volume is the amount of air that is left behind in your lungs no matter how forcefully you try to exhale. There's always something left behind. And then there's minimal volume, and that is the amount of air in the lungs if they were allowed to collapse, and it really can't be measured in a healthy person. And you can also see this sometimes referred to essentially as dead space. And so there's an amount of air that simply you cannot, that is in the conducting zone, that you cannot get rid of and count for. So this is going to require some addition and some subtraction. Nothing more complicated than that when it comes to both lecture and to lab. The numbers that I want you to focus on, and we'll look at a graph here in a moment, are the vital capacity. This is a very important calculation. This is going to be your tidal volume plus the expiratory and inspiratory reserve volumes. There's also what's referred to as the inspiratory capacity. That is just how much can you breathe in. That'll be your vital capacity, or sorry, that'll be your tidal volume plus your IRV. And there's also the functional residual capacity, and that's your ERV plus the residual volume. Finally, there's the total lung capacity. How much can your lungs hold? And that's going to be your vital capacity plus that residual volume. Becoming familiar with a graph like this will become second nature to you. We'll be creating graphs like this in lab using iWorks. You'll be analyzing data like this, and each of you in the respiratory lab will use some normalizing graphs to determine, based upon your age and your gender, what your normal volumes should be, and then you'll actually measure your volumes and see how you compare against the norms. So let's take a look at this graph. 6,000. This refers to 6,000 milliliters, or 6 liters. This is the total volume of the lung. So if you look at the arrow from top to bottom, this would be your total volume, or total lung capacity. Now, we don't ever get to use the total lung capacity. In fact, most of the time, we're not even using much of that 6,000, because most of us are just using this little 500 mils up and down called the tidal volume. So at rest, that is the tidal volume, 500 mils. But there are those times where you are going to take in your biggest breath. And so that is going to be your inspiratory reserve volume. The inspiratory reserve volume, the IRV, graphically you can see is everything above the tidal volume to the maximum that you're able to breathe in. Likewise, there's an expiratory reserve volume, what you would normally not blow out, but you can blow out, go down as low as, that is your expiratory reserve volume. If you take these three values together, take the IRV, the ERV, and the tidal volume, this, and this, now you have the vital capacity. So this arrow from this point to this point is the capacity of, quote, life, your vital capacity. And that's the amount of the lung that you're able to use, forcibly inhaling down to forcibly exhaling. Below that, there will always be a volume that you cannot get to, and that is the residual volume, the residue, what's left behind. So here's that total lung capacity, right, from bottom to top. That's the 6 liters, or the 6,000 milliliters. Now, a person my height would have more than 6 liters, and a person who's only 5 foot tall would have a smaller lung capacity. So this will be based upon height, and men typically have larger lungs than women. So again, when we look in the lab, we'll see height, and we'll look at sex, and we'll also finally look at age, because with age, the compliance, the ability of the lungs to stretch, does decrease. So you'll be looking at the combination of sex, height, and age to determine your normal values. And like I said, we'll also spend some time measuring those values in the lab. We'll also talk about some diseases that contribute or that decrease these values, or could it maybe even increase these values. So we'll use these numbers as normal values. Again, regardless of sex, you're going to have the tidal volume of about 500 milliliters. And then because guys have bigger lungs, they have more of an inspiratory reserve volume than women, and also a greater expiratory reserve volume than women. The residual volume is not that much different, as you see, between men and women. So we'll say 6,000 mils. For men, remember, whenever you look at these graphs, you're looking at that normalized 25-year-old, 150-pound male, and women would have less of a total lung capacity. We'll stop there with that today, and we'll be picking up with 21.11 and be going through the rest of the respiratory system on Tuesday. I will also be recording 2 different digestive lectures. One will be mostly over the physiology of the digestive system, and one that will cover some of the accessory organs, specifically the liver. Those 2 lectures will be lectures that you'll listen to on your own. Then next Tuesday, I'll finish up with the respiratory system. Next Thursday, we'll gather and we'll review, and then our exam will be a week from Tuesday, and that will cover lymphatic, respiratory, and finally the digestive systems.